Uh, we will talk about LV dysfunction and dilated cardiomyopathy, etiologies and evaluation. We will talk about 6 questions and the answers to the 6 questions. Question number 1. What is the definition and incidence of heart failure? Answer is heart failure, or HF in brief, is a clinical syndrome resulting from progressive myocardial dysfunction that compromises ventricular filling and cardiac output. HF patients may be broadly categorized as having heart failure with preserved ejection fraction, or simply HFpEF, defined as left ventricular ejection fraction, simply LVEF, more than 50% to 55%, or patients who have heart failure with reduced ejection fraction, or simply HFrEF, defined as LVEF less than 40%. Heart failure phenotypes have been further stratified to include heart failure with mid-range ejection fraction, HFmEF, LVEF 41% to 49%, which has overlapping disease features and intermediate prognostic implications to that of heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Heart failure with mid-range ejection fraction patients may include de novo heart failure and heart failure patients with previously reduced LV function, left ventricular function, that have recovered heart failure with mid-range ejection fraction. These heart failure definitions represent a continuum of disease on the basis of LVEF, or left ventricular ejection fraction. Categorical distinction is important as there are established therapeutic interventions from large clinical trials for patients with LVEF less than 40%. However, there are no specific therapies for proven benefit for patients with heart failure with preserved ejection fraction. The lifetime risk of developing heart failure is approximately 20%, and the incidence increases with age. Overall survival has improved for heart failure. However, absolute mortality remains high at 50% within 5 years of diagnosis. Question number 2. What is the major pathophysiology of heart failure with reduced ejection fraction? The answer is, despite different etiologies for heart failure with reduced ejection fraction, the compensatory mechanisms, pathophysiology, and maladaptive responses to left ventricular dysfunction are similar. A primary insult to the myocardium, myocardial infarction, myocarditis, genetic mutation, toxins, etc., leads to depression in LV dysfunction, LV systolic function, or left ventricular systolic function, and decreased systemic blood flow. The initial neurohormonal response activates the sympathetic nervous system and the renin-angiotensin aldosterone system, or RAS, to maintain systemic perfusion through vasoconstriction and sodium and fluid retention. However, prolonged activation of the RAS, or renin-angiotensin aldosterone system pathway is deleterious and leads to adverse cardiac remodeling, increased cardiac fibrosis, and inexorable disease progression. Evidence-based pharmacologic therapies in heart failure powerfully target these pathways to stabilize disease and promote reverse remodeling. Question number 3. What is dilated cardiomyopathy, or DCM? The answer is, dilated cardiomyopathy, or DCM, is a unifying term describing myocardial dysfunction with progressive LV or left ventricular wall thinning and dilation and reduced left ventricular ejection fraction in the absence of abnormal loading conditions, as for example, that is hypertension or valvular disease. DCM or dilated cardiomyopathy is the most common form of cardiomyopathy. It represents a shared phenotype for a myriad of cardiac disorders that lead to myocardial damage and chamber dilation. Question 4. What are the common causes of DCM or dilated cardiomyopathy? Causes of DCM include genetic causes, toxins, infection, inflammatory disorders, and collagen vascular diseases. Nutritional disorders, pregnancy, also termed peripartum cardiomyopathy or PPCM. Endocrine disorders, tachycardia-induced cardiomyopathy, and stress-induced cardiomyopathy. So here table 22.1 summarizes the various forms of DCM and management of considerations. This is the table, you can see table 21, the last table, table 21. Here we will get all the management and various forms of cardiomyopathy. Now next question is question number 5. How does DCM or dilated cardiomyopathy present? The answer is typical presenting symptoms of DCM include exertional dyspnea, fatigue, reduced exercise tolerance, weakness or thopnia, paroxysmal nocturnal dyspnea, weight gain, early satiety, nausea, bendopnea and lower extremity edema. Physical examination is notable for elevated jugular vein pressure or JVP, extra heart sound S3 and S4, pulmonary congestion and lower extremity edema. Physical exam signs that are most specific and associated with poor prognosis include elevated JVP and an S3 heart sound. With disease progression and development of right-sided dysfunction, patients can develop ascites, hepatomegaly, cardiac cirrhosis, and worse, cardiorenal syndrome. In advanced heart failure, cardiac cathexia may develop which manifest as muscle loss, temporal wasting, and high degrees of frailty. Now question number 6. What diagnostic testing is part of the initial evaluation for patients with newly diagnosed DCM or dilated cardiomyopathy? The answer is a thorough history and physical examination should be performed on all patients with incident heart failure, as this often provides clues for etiology. DCM may be genetic and or acquired. A careful family history and review of risk factors and toxic exposures must be obtained. The recommended initial diagnostic testing includes a complete blood count, comprehensive metabolic panel, fasting lipid profile, urine analysis, thyroid stimulating hormone or TSH, natriuremic peptide levels or B-type natriuretic peptide or BNP, or N-terminal pro-B-type natriuretic peptide or NT-proBNP, cardiac enzymes, chest radiograph, ECG or electrocardiogram, and echocardiography. So that's all about the 6 questions and their answers. In our next video, we will talk about left ventricular dysfunction and dilated cardiomyopathy, their etiologies and evaluations. We will first set forth the question, then we will answer. So thank you very much for your patient hearing. I hope you have enjoyed listening to this lecture on dilated cardiomyopathy. Thank you, bye bye. And if you like this video, you can subscribe to the channel and you can comment to know more. Thank you.